Oops.
Are we live? Can everybody hear us?
Yes.
Okay.
So I'm getting ready to just let everybody know. Oh, shit.
Okay, so we only have a couple people on right now, but just so everyone has an idea, my name is Alan McGill. I'm the executive chairman of the of NASCA, as well as co-chair of the education committee. And for those of you that are just on now, we're waiting on our speaker to arrive. I understand he may be having some technical difficulties, so it may be a few more minutes. But we are getting ready to get going soon.
So can everybody hear me?
Yeah, I think your sound's good, Kathy.
Okay, thank you. I forgot that I have all the attendees in mute mode.
They are hitting chat, though. They did put in there, yes, so they can hear
you. So we're going to wait a few more minutes if people would just bear with us. So I apologize.
Hello, Kathy.
Ah, thank you.
I couldn't find the link again. It's a doggone thing in this Gmail.
Oh.
It was there, but I had to search through a whole bunch of emails. Whatever.
Oh, all right. Well, at least you're here. So I think we're ready to get going. If Ellen, do you
I mean, it's up to you. Do you want to wait a few more minutes? We only have 9 on the list so far, and I think we had, what, 40 signed up?
Yeah.
Give it another minute or two, and then we'll get started.
And then people will join as they come along. And then I am going to go ahead and I'll run the slideshow if that's all right.
I've got it, Kathy. It's easier.
Oh, okay, good. Do you want to do that instead?
Sure. I'll just share my screen when you're ready.
Okay, so I'm done with that. So you guys can, so there's a couple of slides in the beginning.
Yeah, we'll just give it another minute or two for people to go ahead and join. Start at, I think, 3:05 would probably be good. And I'll do some announcements, and then I'll introduce you, Dr. Davis, and we can get rolling.
Good. Hello, Alan.
How you doing?
I'm doing well.
Good. Warm enough down there for you?
Mm-hmm. We're getting a little rain, very little, but some.
No, that's welcome. I guess any month, right?
Oh yeah. Yeah, 115's been a little warm.
Wow. And I complain when it's 85.
Yeah.
That's a cool breeze for you, huh?
Yeah, that would be nice. Are you in Pennsylvania right now?
I am, yeah, northwestern Pennsylvania, about 30 miles south of Erie, above the lake.
Yep, I know where it is.
Yeah, it's finally we finally got rid of our snow. So
okay.
We always joke and say there's only 2 seasons in Erie: 4th of July and winter. All right. Well, I think we can just begin, and hopefully folks will be joining. Looks like we're getting a few more. So just want to thank everybody for joining us on this webinar of NASCA. We appreciate you spending your afternoon with us. And I just have a few quick things. Dues notices are being sent out now. And our mailing address and phone number has changed just from the last webinar, but in case you missed it. So you can check that on our website at www.nasca.org for that updated information. Just to remind everyone that this year's annual conference has been changed. We are now going to have it at the Drury Hotel Plaza Riverwalk in San Antonio, Texas, from October 25th through the 28th, 2021. We hope to see you all there. It'd be nice to get back to a conference in person again. Travel scholarships, we need to get those in for the Bill Ward Education Award applications as well. And you can download those online at the NASCA website /scholarships as well. So you can check your state's contact information too, so we can make sure that that is accurate as well in the profiles. Same location, you can contact Kathy Keogh when that occurs. We'll keep everybody on mute except for our presenter. And if you could just post the questions in the chat box, as Kathy had just done as well, at the bottom of your screen, and we'll get those to Dr. Davis at the end so he can answer those questions. Today's webinar, of course, is being recorded, and we will share it sometime in the near future as well. So, and we'd also ask that if you take a few minutes at the conclusion of today's webinar to complete the brief survey on the presentation. That's always helpful to us. And I also want to take just a moment and thank our sponsors who, without them, we couldn't provide webinars and all the other educational items that we do. So our platinum sponsors are Apris Health, Indivior, MD Scripts. Our gold sponsors are Greenwich Biosciences, Johnson & Johnson. Our silver sponsors are Hyman, Phelps, and McNamara, Independent Pharmacy Cooperative, Quivia, Mallinckrodt Pharmaceuticals, the National Association of Chain Drugstores, Rite Aid Corporation, and ScriptSafe Inc. At this point, I just want to introduce Dr. Bennett Davis. Dr. Davis is the director of the Sierra Tucson Pain Recovery Program. He's the president, the Integrative Pain Center of Arizona, Tucson, Arizona, and the medical director, Project Echo Pain at Weltzman Institute. So without any further delay, I'll turn it over to you, Dr. Davis. Thank you for being here.
Thank you. My pleasure. Thanks, everybody. I would like to share with you some recent research I've been doing that really relates to primary care teaching, which is a third of what I do now, and sort of tie in that research into what we've been through in the last 25 years and what we're going to need to do in the future now and in the future. Again, I'm going to bias this toward the primary care because that's where I'm getting a lot of my information and my focus right now in teaching through the Weitzman Institute. I do e-consults across the United States, probably 50 a week, 20 to 50 a week at times. And these are primary care providers asking about pain issues. And a lot of it has to do with still opioid medication, pharmacology, that kind of thing. So I want to share with you what I'm picking up, what I'm learning, some of the stats that I've researched and what these people are facing. I'm going to give you, through me, a picture of primary care land, I guess I could say. So the first thing I want to do is go through what we all have learned about who these people are who are prescribed opioid for non-cancer pain. And I'm using that chronic non-cancer pain designation because that's what shows up in a lot of the literature: chronic pain, chronic non-cancer pain. What we're seeing is that people have been prescribed pain medication, including the opioids in the last quarter century, for physical nociceptive pathology. In other words, the nociceptive somatosensory system is set up to protect us, that system that senses too much heat, too much cold, too much pressure, inflammation, and warns us about it to keep us safe. If it doesn't work, we don't survive. That system is engaged because there is inflammation or something going on in a joint or a tissue, a stretch of a hollow viscous, whatever. There's a growing tumor, whatever it might be. That's nociceptive pathology. And that really is the main concept behind that most healthcare providers have of what pain is in most patients. We always look for what's the pathology causing it physically. And we have this concept that if we can't find a physical pathology, it's not real pain. But we've gone beyond that. And I've got a slide or two to help you with that. Also, quite a few people with anxiety and depression using opioids as a psychotropic. This is from, there's plenty of research, and I'll show you some stats to back this up. My own experience too. My own experience was during the opioid crisis between 1995 and 2015, was that many of the patients were actually admitting, who were sent for consults from primary care, admitting to me that, yeah, I use this because it calms me down. To heck with the pain. I don't know about the pain, but I use this because it calms me down. And they did not have opioid use disorder, not even difficult even to categorize them as mild, but certainly not moderate or severe. Patients with no physical nociceptive pathology, that third bullet point, perhaps chronic pain due to untreated trauma and grief. This actually has been given a name that I want you folks to share with you folks in a slide coming up. This has been given a name as a third type of pain. I'll come back to that. These are people who have changes in their nervous system that report pain to the brain when there's nothing wrong with the tissue. So think phantom limb pain. There's no foot, but the foot is perceived as hurting. Phantom limb pain comes around from a physical injury, crush, amputation, that sort of thing, to nerves in the leg. When there's nothing like that going on, it still turns out that the nervous system with certain experiences, particularly trauma and grief, can change, can be rewired such that it reports pain when there's nothing wrong with tissue. That was a lot of people. We're going to talk about that. How many? People with opioid use disorder were showing up and being triaged to appropriate treatment, and people were diverting opioids less and less, but we saw that too. And of course, we saw mixes of all of this in 2s, 3s, and sometimes all of it. Those are the people in the last quarter century that were, I think that's probably an inclusive list, were prescribed opioid. So let's talk about those 2 bullet points: people with anxiety and depression using opioid as a psychotropic. And I did go through a talk, I think it was last year, no, I missed the COVID year, 2 years ago, where I went into a lot of detail explaining these concepts. And Kathy, I don't know if that's still available to these folks if they want to see that, but I can send a link to a webinar if you'd like. You can disperse it to people who would like it, where I go into a lot of detail about opioid as a psychotropic and the trauma pain connection. The animal data, suffice it to say that animal and human data strongly support anxiolytic and antidepressant effect of opioids. Patients suffering from PTSD, so those 2. I have been digging through prevalence information on this, and I think I've got 4 or 5 slides on this, but it's interesting to look at. First depression, then we'll talk about anxiety, then we'll kind of synthesize that, and then we'll talk about trauma. So it'd be interesting to know what the prevalence of depression in the chronic pain patient group on opioid versus the chronic pain patient group not taking opioid would be, versus the general population as a baseline. And here's what you see. What you see is the prevalence of depression in the general population around 8%. In patients with chronic non-cancer pain, 30 to 54%. And in patients with chronic non-cancer pain prescribed opioid, higher than even the range with the general range of all chronic pain patients. So that sort of says, you're more likely to get opioid if you're depressed. Remember, more likely than other people with chronic non-cancer pain. By the way, these, in labeling people as depressed in these studies, they're using tools like the PHQ-9. They're not simply saying, do you feel depressed? And again, with anxiety, these studies address people who are diagnosable with generalized anxiety disorder, not just saying they're anxious. Prevalence in the general population, around 11%. Patients with chronic non-cancer pain, somewhere around 20-25% in that range there, order. And down at the bottom there, prevalence in chronic non-cancer pain prescribed opioid, almost 50%. Again, sort of the same finding as with opioid. It says that you're more likely to get opioid if you have chronic pain, if you present with anxiety as well. And then Davis did a study, and not me, Davis, M. Davis, and published it in 2017. He looked between the previous 5 years or so, how were we actually prescribing opioids? It turns out the majority of the opioid went to people, the minority of Americans with mental health diagnoses of generalized anxiety disorder and major depressive disorder and so on. Another way of looking at that is that patients with GAD and depression were about 4 times more likely to be prescribed opioid painkillers. So that was pretty striking. Let's talk about PTSD. I think someone might have their mic open. If you can check and see if your mic is muted, that'd be great. Thank you. I still hear a mic open. Okay. So the prevalence of PTSD, same idea. General populations, about 9%. The chronic non-cancer pain population, about 25 to 42%. What I threw in there was combat veterans as a baseline and sort of a novel stat there, physicians around 15%. That surprised me, but maybe it didn't. And that might be one of the barriers for medical personnel, preventing them from having discussions about trauma with patients if one out of 8 or 1 out of 7 really traumatize themselves. So again, Kathy, I don't know, I don't have control, but maybe you can mute that group. So the chronic non-cancer patients were much more likely to have PTSD. And this is a second study looking at it. In looking at the literature, 152 or so studies, 10 were picked that were good. Consistently, patients prescribed opioid were more likely to have PTSD. Conversely, patients with PTSD were more likely to be prescribed opioid. And consistently, this kind of gets you, patients with PTSD with chronic non-cancer pain were prescribed more opioid, more likely to get more than 1 opioid, and more likely to get benzodiazepines co-prescribed. In a way, not surprising, but it's good to just see that data. And this is sort of borne out if we relate the stats to clinical research on chronic pain. The 2 studies that looked at what predicts people moving into the chronic pain group and what predicts people who stay there, that's these. From around 2005. This prospective study, very well done by Eugene Carrigy up at Stanford, he looked prospectively at a large population who had no pain to find out what factors, psychological and physical, job, social, might predict becoming a chronic back pain patient. And lo and behold, only psychosocial factors strongly correlated, strongly predicted. Poor coping skills, and several others, anxiety and depression. Only psychosocial, psychological factors predicted the transition to chronic pain. So if you look at it the other way around, as Nemithno did, how about people that are stuck in the chronic pain population? What factors predict them not responding to conservative treatment with their chronic back pain? They won't respond to physical therapy, exercise, and so on. Acupuncture, all the good things we talk about with multidisciplinary care. Well, the only thing that predicts that people don't respond to care as usual, conservative care for back pain, is depression, anxiety, generalized somatic complaints, poor life control. And they concluded that psychosocial factors are the difference. So that gives you a good look at who's in this population of people that were presenting for treatment of pain. And we went through this experiment of addressing it pharmacologically the last quarter decade, primarily doing it that way. We can't do this without talking about cannabis a little bit. What was really interesting about this study is they did a pretty good survey of cannabis users to ask the question, how many of you who are using cannabis are using it as a substitute for prescription drugs? And it's about half. So that supports the notion that a lot of our perhaps opioid and so on prescription receivers in the last 10, 20 years have moved on to cannabis because the most common class of drugs substituted were opioids. And that last one there shows us that actually the triad of pain, anxiety, and depression seem to represent the majority of them. That's what the majority of these folks who transitioned to cannabis off of prescription drugs actually were being treated for all three of those things. Again, that fits with the data I gave you earlier. So that gives you an idea of who we're seeing. And I'd like to take a moment to tell you about a real case that I saw 15 years ago. And the question attached to this is, can real pain occur for only psychological reasons? But I want to drive the point that I've been making here home. This is her pain diagram. He presented, he's a school teacher who presented, mother of 3 kids, on disability for pain, short-term disability, hadn't worked in over a year. Her primary care said that she was taking too many opioids. Can you help her get off the opioid? Nothing seems to be working. Conservative care isn't working for this pain all over. 3 years of diffuse pain, and she tried all the usual pharmacologic approaches. Oxycodone was 120 milligrams per day in 30 milligram immediate release preparation form. She was diagnosed with fibromyalgia, but she'd also been diagnosed and had it taken away, lupus, chronic Lyme disease, and I think multiple sclerosis. And for the chronic Lyme, she'd spent a whole lot of money on that. None of that helped. So with this patient, I spent a long time knowing what I've just showed you, being aware of the likelihood, their psychosocial factors, trying to pull them out. Didn't really get anywhere. I mean, she was definitely very flat, depressed, wasn't sleeping well, terrible sleep, and doing very poorly. She would say fatigue was really the main problem she had, more than even all over pain. As they were walking out of the clinic, her husband stopped her. He'd been listening to the questions I was asking, turned around and said, "You know, honey, about a month before it started, you were caught up in a hostage situation. A sheriff's deputy actually shot the man that was holding her hostage out from behind her, kind of Hollywood style. It was in the papers here in Tucson. She was physically unharmed. That preceded the onset of all of this stuff and all the medical treatment. And it's a great demonstration of this, of what people were missing. They were looking for the physical pathology, and it was actually this third type of pain. So you all know, the International Association for the Study of Pain is who we have given over the controls to giving us a definition of what pain is and what causes pain. And they recently revised their definition of pain to include a third type of pain. This is kind of like the International Headache Society gives us the taxonomy on headache disorders. And so ISP does the pain. And there's a link if you're curious to look more into this. So they gave us a third type of pain. What are the first and second? The first type of pain is nociceptive pain from activation of the nociceptive system. The second type is neuropathic pain from physical injury to the nervous system, whether it's a stroke, diabetic, metabolic injury, phantom limb pain from amputation, trigeminal neuralgia from pressure on the trigeminal root, whatever it is. Neuropathic pain is number 2. So now we have 3. And I hate the name, but they called it nociplastic pain. It's a smush. It's nociceptive pain, but not quite. They're trying to incorporate the idea that there's neuroplasticity involved. And what they call it, what they describe this as pain that arises from altered nociception. In other words, a change in central processing in the nervous system. I explain it to patients as a rewiring, despite no clear evidence of anything physical. So they go on to say no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors. It's not nociceptive, or evidence for disease or lesion of the somatosensory system, meaning no nerve injury. And that came out in 2017. We have a name for what that gal had. We have a name for what the majority of these folks that were rolling into my pain practice and the University of Arizona pain practice between 1995 and 2010. By far the majority, 2 out of 3 fit this. So here's a profile of a typical primary care patient that it came up 2 months ago, I think. The daily MME morphine equivalence is 90, back pain for 25 years, failed physical therapy. Well, having showed you all this data, it's a dead giveaway what we're probably dealing with. And sure enough, I wanted to show you what boxes the patient would check on psychosocial screening tools. Their pain is the worst it could possibly be. Average pain level now, 5 out of 5. Can't be worse. This is the GAD-7 screening for anxiety. They pegged it, they maxed it. You know, at the carnival, when you hit the little thing with a hammer and the weight goes up and rings the bell, this person rung the bell. You can't score higher. Bad anxiety. And I don't think we have the depression questionnaire in there, but bad childhood trauma exposure. You can't get much higher than this. 10 is the maximum, and they included sexual trauma as a youngster. 9 out of 10. Really significant, strong, severe pan-childhood exposure to traumatic events and life-threatening events. That's who that was. And when I said 2 out of 3, this is what I'm talking about when you start screening them. And so we found out what happens if we taper these people, not really knowing what I'm telling you, and not really knowing who we were dealing with as a nation, as a healthcare system. We didn't really appreciate this. In 2010, when we became enthusiastic for opioid tapers, the FDA warned us off, as you all know, 2019. That second paragraph, rapid discontinuation of opioid can result in uncontrolled pain and withdrawal symptoms, and so on and so on. They actually give a nod towards the patient may seek street drugs, basically, which may be confused with drug-seeking abuse, and they may attempt to treat their pain and withdrawal symptoms with illicit opioids and so on. We saw a spike in bad things, in suicide, psychiatric admissions for opioid withdrawal, and precipitated depression, anxiety, suicidality. So how do we change course and response? That's sort of a brief tour of, as it relates to treating chronic pain and the or enthusiasm for doing it pharmacologically. The last quarter century, I've lived through it. Most of us have. Have we changed course? Carefully read the 2018 HEAL initiative, and maybe not. We're still focusing quite a bit on the addiction side, not complaining. We saw a lot of accidental overdoses related to addiction and the damage that addiction does, opioid use disorder does, when way too much oxycodone was released into the public sphere in the last 20 years. Of course we did. But the focus here in relation to what I've been telling you seems to be incomplete to me. So the idea here, this press announcement, was to study the causes of pain and addiction and implement and test treatment models to research integrated behavioral interventions for medically assisted. Now they're focusing on addiction again, Matt, and opioid use disorder. Kind of back to that. I think this is where we've missed, and evidence from Von Korf, who's an excellent epidemiologic researcher, to show that as of 2017, we hadn't really impacted the rates of prescription opioid use disorder with all our interventions up to that point, which says probably this approach isn't quite complete enough. Let me tell you about the experience in California then. I'm going to wind up maybe just a little bit early, Kathy, but that's okay. So I told you that I do a lot of e-consults, and I've been doing that for, I don't know, 2 or 3 years. It, of course, got more common during COVID. So these are consults from primary care providers, almost exclusively in community health clinics, in the FQHCs, the federally qualified health centers around the country. All of a sudden, about 4 months ago, I noticed a lot coming in from a certain part, the Central Valley of California. Now, I'm not revealing any privileged information because this has been in the press. I I checked before showing this. A large pain clinic had a captive population of around just shy of 4,000 people, I believe. That's what the press was reporting in California. Mostly prescribed opioids on, rinse repeat cycle, coming back every month and all that sort of thing. Who were, the primary care had referred to pain management for this kind of stuff. It closed suddenly, and all these people showed back up in primary care. So my e-consult panel lit up. And this is happening in 2 other places. This is not unique. It's happening in 2 other states, which I probably won't talk about today. And it's probably happening in more. These are just the ones I'm plugged into the e-consult. Now, so in the e-consult, I get to see the patient's chart. I look through the chart, every single patient. What do you think's there? Anxiety, major depressive disorder. PTSD is actually in, I'm grateful to see they're making the diagnosis, but it's in quite a few of the charts. That's the population of patients that were captured in this sort of opioid suspended animation. That is the opioid crisis. Now, if those people get stressed, they're not resilient. They don't have good stress tolerance, and they might take extra pills or drink and have the accidental overdose. So the big problem there is finding which of these 4,000 people or so are safe to even write another prescription. You can imagine the stress this has put on the primary care system with their 15, 20-minute visits and taking care of all the other medical problems, and not a behavioral health and substance counselor available to them right then and there. So we've got this group of people that my group wrote this article 2 years ago. We're kind of running them through this, saying, well, read the article and talk to us about whether or not you can execute. And this is what I want to share with you. They can't execute very well in Central California. We are trying to figure out how to support them in doing this in the essential steps. The essential steps for the reset for them, the forced reset, they're being forced to, is harm reduction mandate. They need to identify who is at risk for accidental overdose this month, and I better get them into different treatment with an ESPER strategy. This isn't necessarily for opioid use disorder, because the majority of these people, it's looking like they don't have opioid use disorder. But many of them are still at risk. I can tell just by reading the chart, and I've spoken to some of the primary care providers in follow-up. So the first mandate is harm reduction. Triage out the people that are immediate risk, get them into whatever sort of behavioral health or substance use disorder treatment they need to improve survival rate. That might be able to be addressed by e-consult, and we're working on that. We would really need a behavioral health and medical person. Right now, it's medical. We need a behavioral health person to support that primary care population, and we would need a fair amount of bandwidth because this has all hit them at once. The second step in the reset is for primary care providers to be able to refer out to behavioral health resources to address the issues that I've run through with you and that we've exposed. In a way, we've exposed the Achilles heel of our healthcare system with this whole experiment, that's what I'm going to call it, of OxyContin and a lot of opioids out there. We've really exposed our Achilles heel. It's become quite apparent that behavioral health providers need those behavioral health resources to perform functions. I'm going to take a shortcut that are described in the Health and Behavioral Intervention and Assessment CPT codes. Those were released by Medicare in 2000, by CMS in 2002. They're not new. And they describe how behavioral health providers can be paid to provide services for medical diagnoses. The original idea was heart disease, because we knew that after a coronary artery bypass and graft, most patients, the most likely reason people would have a second and third bypass surgery would be behavioral. They didn't change their eating habits. They kept smoking. Anxiety and depression weren't addressed, so they went back to what got them there in the first place. In this case, it's addressing the same issues, but which are manifesting as pain, as that nosoplastic pain, or which have been treated with opioid, the anxiety and depression that has simply been treated with opioid as a psychotropic unknowingly to the providers. They didn't necessarily know. I see some chats. We'll have time. I see 4 right now. We'll have time to talk about questions in just a moment. So those are the HABI codes. Unfortunately, many states will not allow master's prepared behavioral health to do this. It's only psychologists, PhD psychologists, and Medicare will only allow, as I understand it, PhD level psychologists to bill for these. So the majority of the behavioral health workforce is not PhD psychologists. So we have this mismatch, this problem with our workforce that we need to fix to support the primary care providers to deal with not only the California issue, but to deal with this issue as a nation. So those are the two things that we need to figure out if we're going to actually reset and address the opioid crisis. And that's all I have to say. Appreciate your folks listening. Let's look at the chat. Yes, open mic. Okay.
Yeah, that's me. And
actually, the chat was just you working
yeah.
Yeah.
I'm horrified, and I really do have to apologize to everybody. And speaking of pain, I'm actually at my aunt's house who's in hospice. I had no idea it was. Oh my goodness, I am really sorry. So if people do have questions, certainly type it in the chat box or the Q&A box.
I do have a question, Kathy, though. I think I'll just say it on the mic if I could. Dr. Davis, is there any, are you guys addressing things with the insurance industry in order to deal with some of those issues regarding medications for patients, as well as you said, some of the behavioral health component? The reason I'm asking is because I have a friend of mine who was an agent. He was shot on the job. He experienced a lot of trauma. His health has deteriorated over, he's retired. And he's had diverticulitis, and he's a lot of pain with that. And he's on a biologic, which seems to cause it. But the long and the short is, he has to go to this one medication that is somewhere in the neighborhood of $250 copay a month, which he simply can't afford. And the insurance company won't approve that, but they'll approve the pain medication all day long.
Right.
And, he worked in diversion, and he said, aren't you guys, he actually asked them this, aren't you guys, putting patients at risk for developing an addiction when you don't need an authorization from a doctor? You'll approve these pain medications. You don't need the prior authorization, but I can't get the biologic. And is anybody looking to address those kind of issues as well as get those behavioral health issues taken care of? Because I think you're right. We're seeing all this, and if people can't afford it, then how are we getting the professionals paid to get that treatment out there?
It's all about what we pay people to do, right? And that's what you're underscoring, Alan. We pay people to prescribe medications. One primary care recently told me I'm getting out at age 35 or 40, not really retiring. I'm going to do something else because I feel just like the tip of the spear working for the pharma industry. So they're paid well to do that. So that's what they do. And we're paid well to do procedures and that sort of thing. I actually have records from United Healthcare from early 2000s. They were paying over $10,000 a month for OxyContin. Or $5,000 a month it was for OxyContin, over 1,000 milligrams a day of opioid. And insurances, as you said, we're happy to pay that bill. That would have treated that patient and their whole family and their neighbors, both sides left and right, with good behavioral health care. 1 month of that. So the problem that we have is in the insurance industry, and it is nobody that I am working with is having any success making any inroads with the health insurance industry. CMS is brought up the HAVI codes, brought those out, and that's really a good move, only they're underfunded. We talked to behavioral health people, it's only psychologists, and they say, well, no, why they're paying me a third to half of what I make in private practice, why would I do that? I can just cash pay and skip the Medicare sign up and all that kind of stuff. So they're underfunding the actual execution of those HAVI codes. In fact, I would say, get on my soapbox for a moment, I would say that, when I hired the psychologist that I've worked with, when I was at the University of Arizona, we hired her. She came out of a crumbling industry, and that crumbling industry was multidisciplinary treatment of pain that was mainly run by behavioral health. A lot of people have forgotten this. Behavioral health providers ran, quote, pain management to a large degree in the 80s and early 90s, but health plans kind of pulled the plug on that, even though there was really good data to support efficacy. That's all out there. In about that time, 95, what happened in 95? That's the launch of that is the launch year, I think, of OxyContin. And so along comes OxyContin as the replacement, in a way, I'll paint it this way, to combined behavioral health treatment of pain. It didn't work very well. So here we are, trying to rebuild that system that was shut down. I have had like zero success. The insurance industry is layered, and you really, to get to decision makers, I never have been able to do that. It isn't necessarily in a health plan's best interest to fund behavioral health, because the benefit of funding behavioral health typically accrues to the physical health side. Less ER admissions, fewer ICU stays with overdoses, fewer of the physical consequences of heart attacks, in the example I gave, coronary artery disease, fewer of the physical consequences of those behavioral health issues. This whole little presentation I gave is talking about the behavioral health root of physical issues. Well, why would a behavioral health insurance fund more behavioral health treatment when the return on investment accrues to the physical, another health plan? They don't get any ROI at all. So there's a lot of structural things that are wrong with our healthcare system. If anyone is interested, Michael Porter at Harvard is an health economics professor there. There are a couple more, Victor Fuchs and others at Stanford that have written, but Michael Porter's written some really good stuff on what we need to fix in the health industry, and we haven't done it.
Well, I will say, this is Kathy, I will say that your soapbox has actually generated a couple of questions, so that's good. So one of them is, thank you for your time. How do you feel about the use of ketamine for the treatment of depression? What would be your best practice for these types of businesses?
So the best practice for treatment of depression is get at the root issue, which often is trauma, has the most long-lasting, life-changing benefit to it. Again, ketamine is going down the path of, we're going to treat things pharmacologically no matter what. But having said that, there's evidence that ketamine and all of the psychedelic drugs do some things to induce the rewiring of the brain in the right direction and reduce depressive symptoms and other behavioral health symptoms. There's pretty good evidence that it's effective. Doesn't last forever, probably. There is a little bit of evidence of some lasting benefit, which is really cool. So I'm all for it, and I don't know a lot about the businesses because I'm not in that industry. It's being used a little bit for pain and some other things as well, with less efficacy, as I understand it.
Okay, another question is, have you seen anything that helps pain with post-polio syndrome, spinal stenosis in particular?
So spinal stenosis is a physical narrowing, narrowed coronary arteries that we treat physically. It's a physical narrowing that constricts and puts pressure on the nerves, kind of like carpal tunnel in the wrist, but it's carpal tunnel in the whole spine there. So it causes pain radiating down the legs, of course, with standing and walking. Quite apart from post-polio syndrome is a whole nother thing. And post-polio syndrome is probably a chronic low-grade inflammation of the nerves, peripheral nerves, and in the central nervous system as well. So treating spinal stenosis is more about lifestyle. Number one is always lifestyle. And that's the hardest thing for us, anyone in primary care, to make any inroads on. So we don't really have the tools to help patients affect lifestyle change. But lifestyle change plus sometimes surgeries and things like that, it's a mechanical problem. And I will say that properly selected patients, particularly patients who do not have untreated PTSD, by the way, that predicts bad results. But properly selected patients, surgery for spinal stenosis is pretty effective. It's a physical impingement on the nerves. Post-polio syndrome is something totally different. Immunotherapies and the standard nerve pain medication therapy. So if you look up the treatments for diabetic neuropathy and that sort of thing, that's what I'm talking about. The gabapentin, duloxetine, those types of medications. Acupuncture and cognitive behavioral therapies can be very helpful. Depends on the patient. All of the therapies getting at any sort of nosoplastic pain, the trauma therapies and grief therapies will help a lot if that's what's going on. And it's pretty a lot more common than we think. So I mentioned the medications, but I'll wind up my answer by saying don't forget about evaluating for and treating the nosoplastic.
Okay, and then another question. Is there evidence to support a hypo-opioid syndrome, people who do not produce adequate levels of endogenous, oh my God,
Endogenous opioids, I'm with you.
Thank you. Leading to a depression-like state. Do they respond to small dose opioid therapy?
So I would say the concept of just not making enough isn't necessarily correct. So in our bodies, we make endorphins, and endorphins are chemical ligands that bind to receptors, classic receptor ligand pharmacology. So we have opioid receptors. And it turns out, this is interesting with regard to this question, that there are people who have certain subtypes of opioid receptors. So just like blue eyes, brown eyes, green eyes, there are different subtypes of Mu1 opioid receptors, for example. So people that express a certain type of opioid receptor tend to be more likely to develop depression and anxiety and respond really well to low-dose opioid treatment. And there is research looking at buprenorphine and other medications as treatment-resistant depression as an option there. Not first line, but treatment-resistant depression with some pretty doggone good results. Animal models of depression with opioid also shows that they're at least somewhat efficacious. It's going to turn out that there are phenotypes with people who have genetic predisposition to having a problem with the endogenous opioid system, probably certain types of receptors that makes them prone to depression, and opioids would be helpful for them. The big model for depression now is looking at inflammation. I think is not looked at as a deficiency of serotonin and norepinephrine. A lot of attention to neural inflammation is kind of the root issue and what kicks that off. But yeah, that is correct. The opioid receptors are involved in the limbic system and regulation of mood and memory and a whole lot of things other than pain. And manipulating the endogenous opioid system or giving exogenous opioids, such as buprenorphine, can be helpful in some cases of depression.
Okay, yeah. I do not see anything more in the Q&A and chat box. We'll give people just a couple more seconds in case they had a question, and then Ellen can wrap it up.
Yeah, what's to say about slides with statistics? Those, I will tell everybody that if you do save that and look over those slides, it takes a while to digest what they mean. Almost every other day, I think, I have something new, a new light bulb go off once with those stats sort of kicking around in my head about why we're seeing what we're seeing in our country and what we ought to do about it.
Well, it doesn't look like we have any more questions, Kathy. So
no.
I want to thank you, Dr. Davis, for being here today. I appreciated the lecture. I heard part of it the first time a couple years ago in Arizona, and I enjoyed it then, and I did today too. So it's a new perspective for me, especially as an investigator looking at this. So thank you very much for being here. Thank everyone else for participating and being on the webinar for us, and we'll hope to see you in San Antonio.
Thank you.